مساء الخير. نرحب بكم في الجلسة السادسة من PCI MENA. في عندنا 4 محاضرات. يسعدني أن أقدم زميلي دكتور ليث موسى. الآن هو إلكتروفيسيولوجيست انضم لنا في الأردن وبيشتغل في القطاع الخاص وفي الجامعة الأردنية. راح يتكلم عن Periprocedural Management of Patients with Cardiac Implantable Electronic Devices.
مساء الخير أولاً جميعاً. Thank you for inviting me. It's a privilege يعني أكون موجود هنا وأحكي معكم. اليوم اللي بدنا نحكي عنه إحنا Periprocedural Management for Cardiac Devices or for patients with Cardiac Implantable Devices. تمام. طبعاً I have no disclosures for this talk. راح نحكي عن ال cardiac devices in general, risk assessment and pre-procedural planning. بالإضافة طبعاً لأنه بنحكي عن ال management strategies inside the procedure and then post-procedure management وشو بدنا نساوي. The main resource for this talk is the AHA scientific statement من 2024 circulation publication. And then the British Heart Rhythm Society publication for guidelines for perioperative management of people with cardiac implantable electronic devices. So basically, why do we implant devices? We have a few reasons why we implant devices. أولاً bradycardia because of either a sinus node dysfunction or AV block. هدول المرضى بيكون في عندهم pacemakers typically. Of different kinds, single chamber, dual chamber, ممكن يكون عندهم leadless pacemakers. Second device is ICD or implantable cardioverter defibrillator with all its variations, and this is for studying cardiac death management, diagnosis and then treatment with either ATP or shocks. And then third is CRT or cardiac resynchronization therapy for patients with heart failure and conduction disease, where we implant devices to coordinate the septal and the lateral wall of the LV to improve the heart function and symptoms and mortality. It's very important when we talk about devices, for surgery, assessment of the patient dependency on pacing from the device that they have. So we're going to talk about all this in detail today. The risk assessment and management of patients with cardiac devices is really an ongoing process. أول ما المريض يصير في عنده cardiac implanted device, we automatically know that there is a chance at some point that they're going to need surgery, and we have to always plan ahead if the surgery is needed. Personally, in my office, there is the electronic health record that I use. بيكون في عندي flashing note على أي واحد عنده device إيش نوع الديفايس وشو هي and dependency. أنا بيكون مكتوب مثلا عندي CRTD, Boston Scientific, patient is dependent, because I need to know this. فهذا الحكي بأول يعني the first top left circle is basically the remote monitoring and the follow-up. Next is pre-procedural planning. What is the surgery? What is the risk for the patient? And what we should do for the surgery. Third is intraoperative management. And then obviously fourth is post-operative restoration of the device settings and making sure that no complications have happened. On the device, we need to know what the cardiac rhythm status is, what the dependency is, the battery life, the threshold, the lead impedance and sensing, as well as testing and making sure that the magnet function is actually working with the device. This needs to be done before the surgery for all surgeries that involve cardiac devices. On the patient or device side, we also need to know what kind of device there is. I put a bunch of x-rays. They're not really to differentiate now, but looking at the x-ray, both PA and lateral, we can get a lot of information about the devices, if it's leadless or lead, if it's dual chamber or single chamber, ICD, dual coil, single coil, كل هذا الحكي ممكن نعرفه من x-ray. And then about the procedure, we also need to know a bunch of information. أولاً, where is the site of the procedure? Is it in the chest or is it in the abdomen? And then we need to know where the device is. Is it in the chest or the abdomen? Cautery, are we going to use electrocautery or diathermy of any kind? Is it going to be monopolar electrocautery, which is the dangerous kind? Because in monopolar, we use the cautery on the wound or in the pocket, but then the grounding pad is somewhere else on the body, which means that the electrical signal is going to travel through the body and it might actually affect our device and cause oversensing. And then if the generator is in the abdomen, it's a special consideration where the EP or cardiologist needs to be consulted. And I just want to spend a few seconds on this. ليش بنهتم فيه? It's really, you have to just assume that EMI is going to affect the device. Because if it's in the abdomen and the surgery is in the chest, the surgery is still close to the leads. And the elements have to be completely far away from the surgery, the device and the leads, to exclude EMI. So any surgery where the device is in the abdomen still needs to be treated as an EMI surgery if it's going to be used electrocautery. Intraoperative, I'm going to go over this briefly from the surgery standpoint and where the surgery is. Generally speaking, if the surgery is below the umbilicus and the device is above the umbilicus, meaning in its normal place in the pocket, in the left chest or in the axilla, these patients generally will not see EMI, especially if you place the pad in the correct place, which should also be away from or under the umbilicus. In this case, there is very minimal EMI and the patient should be just monitored regardless what the patient's situation with the device and dependency is. Monitoring means close monitoring during the procedure with ECG or a cardiac monitor, and a magnet should always be available. But if your surgery is below the umbilicus and the device is above, then you should proceed with caution. If the surgery is above the umbilicus and the device is in the chest, then that means that EMI is likely to happen. In these cases, we always say a magnet should be available for disabling the ICD, or to use with patients that have pacemakers or ICDs with dependency on the pacemaker for pacing. Meaning, if you have an ICD with no dependency, then the only thing that we need to disable is the ICD function, which is the magnet. If you have a patient that has a pacemaker and they're dependent on the pacemaker, the magnet will actually cause asynchronous pacing. So these also should be treated with the magnet throughout the procedure. And then we have basically all patients with device below the umbilicus in the abdomen. It's ideal that you consult with a cardiologist before proceeding with the surgery. I'm going to ask you also راح أحكي عن هذا الموضوع from the EMI risk in a little bit, which is maybe a little simpler to discuss. I include these two examples because we want to emphasize how important it is that EMI should be considered and caution should be taken. The first example on the top is an ICD where the patient is also V pacing, if you see. So this is V pacing, V pacing, V pacing, V pacing. بعدين هون بصير في عندنا EMI أو electromagnetic interference. So تحت بصير في عندنا oversensing, and you can see it here, oversensing, and there is no signal from the RV. So the device thinks that the RV is tachycardic. There's tachycardia coming from the ventricle, which is VT, and soon enough it will cause ATP and then a shock. Plus, in this particular patient, the patient is also dependent. There's no signal from the sense signal, which means that the patient is also not being paced. And that's very important to be considered before the surgery. The second option is the same, but for the pacemaker. And you can actually see this EMI is not from surgery. And how do we know this? Because the EMI is mostly on the V lead, not on both leads. The A lead is actually okay. But even though now we have oversensing and no pacing, so this patient has whatever many seconds here, maybe 4 or 5 seconds with no perfusing rhythm. Monitoring during the procedure is very important. Continuous monitoring with ECG, prompt troubleshooting. You have to always be able to address, first of all, recognize and address problems, which is either repeated shocks or underpacing because of the oversensing in the device. Specialist collaboration is also key, obviously. إذا كان في أي شك بالprocedural management, then cardiologists or EPs should be consulted to discuss the proper management for sure. Post-procedural, obviously device function confirmation doesn't affect the device is actually okay. Many of the surgeries, we didn't really discuss this because we don't have the time for it, but many surgeries can actually happen in close proximity to the device, or intravascular surgeries or procedures where the leads also might be moved or dislodged. So we have to make sure that device function is working properly after the procedure, make sure that we restore the procedural or pre-procedural settings for the patient, address all abnormalities quickly because the quicker we deal with them, the better for the patient, and make sure that the patient is always educated and informed of what is happening with their device. This is another summary of things. This comes from the circulation publication, planning for pre-procedural and inter-procedural management, and then post-operative confirmation of the device function as well as restoration of the pre-procedural settings. So in short, we have to actually have comprehensive understanding of the patient, their device, why it's there, the indication, as well as the dependency for all patients, and then careful planning for the procedure. The magnet is generally a safe option, except in few cases that I will actually mention because we have a few minutes to actually discuss that, and I will mention them in the next slide. And then multidisciplinary coordination with involvement of the cardiology or the device management team should always be on the table. Another way to actually go about this is the risk of EMI should be assessed before the surgery. If the risk of EMI is low, meaning the surgery is below the umbilicus and the device is above, then proceed with caution. Make sure that you're monitoring the patient and make sure that you have a magnet inside the room. This goes for all patients, dependent, not dependent, ICDs, pacemakers, everyone. And then in high-risk patients, high EMI risk, meaning, like we have the device in the chest and the surgery is up top, or the device is in the abdomen, then pacing dependent patients with, number one, ICDs, number two, micro devices, which is a leadless pacemaker that Medtronic makes, difficult access to the device, for example, left shoulder surgery or left chest surgery, and then prolonged EMI expected during the surgery, either because of endoscopy or like surgery that needs electrocautery or organ electrocautery that is prolonged. These patients should really be reprogrammed before the surgery. عشان نريح حالنا, because we want to, free up the anesthesiologist. If this is frequent EMI during the surgery too, we can't just expect the anesthesiologist to just focus on the rhythm and forget about the anesthesia and the hemodynamics and everything else that's going on. So these are patients that need to be reprogrammed before. All other dependent patients with a pacemaker or ICD patients that are not dependent with a stable underlying rhythm, you can use magnet and monitoring during the procedure. And then lastly, all pacemaker patients who are not dependent, you can monitor with magnets being in the room without intervention. Last thing I want to mention really quickly is, and I know that many of you probably know this, magnet function in an ICD is a device فيها ICD, regardless if it's a dual chamber, single chamber, CRTD. If there's an ICD, what magnet does is it disables tachycardia therapy, no effect on the pacing algorithm or mode. So if the patient is dependent, you have to always reprogram the patient before if there's risk of EMI. On a pacemaker, most pacemakers, the exception is the one that I mentioned, which is micro leadless pacemaker. Most pacemakers with a magnet will go to an asynchronous mode where there is continuous pacing, no sensing, so that even if there is EMI, there is a stable rhythm during the case. And then the last note I want to actually mention is dependency is not just a rhythm, it's a clinical diagnosis. So we need to know that there is a rhythm and it's a perfusing rhythm. So 35 beats per minute may be enough for many people, but for some people it should be 60 or 70. And with that, I think I will finish. This is just from the British Heart Rhythm Society, also a nice summary, but I'm not going to go through the details of that. And I think questions بعد مش And thank you.
Thank you very much, Dr. Layth. Thank you, Dr. Layth, for a very interesting presentation. Our next speaker is Dr. Hazem Habboub, well known to everybody, our most senior interventional radiologist with extensive experience in public and private practice, and a good friend. Hazem will present to us physician-modified endovascular grafts, a new hope for life-saving aortic arch disease.
Thank you, Ma'moon. Thank you, panelists. I'm glad to present for you something that we have done for the first time here in Jordan, probably in the whole region, which is the use of PMG, which is a physician-modified endovascular graft for the treatment of aortic arch diseases. I'd like to thank Dr. Ma'moon because he encouraged us to do this, and he was the power after this procedure and after this achievement. And I'd like to thank Dr. Uday, who prepared me with all the cases that we collected. So I'll start with the case, and this is a 42-year-old male patient. He's a patient of Dr. Ma'moon. He is a known case of Behçet disease, and he had a previous aortic surgery for an aortic arch by having a bovine pericardial patch graft for the aneurysm in the arch of the aorta, segment 3. And the patient presented recently after 1.5 years with recurrent epistaxis. The epistaxis was hemoptysis. The hemoptysis was so coming in episodes, and most of the time they were controlled. Recently, it started to be more vigorous, and the patient he started to have as well hoarseness of voice. And on the CT scan, you can see that there is a false aneurysm and probably an aneurysm of the arch of the aorta. This shows the patient previous surgery. So this is the angiogram, and at this stage, we were planning to do a fenestrated graft for him, as I remember, but the patient he presented with severe hemoptysis, so that we have to think of other solution for the patient to save him. So the idea of having PMEG graft was raised by Ma'moon. I said, let's do it because we have to save this patient. He's young and we have to do it. So this is the angiogram, and you can see on the left, side, the false aneurysm or the intramural or the ulcer with false aneurysm. And what we have done, we brought the graft. There is a graft that's now well known that you can do a PMG on it, which is the LifeTech graft. So what we do, we took the measurements from the control angiogram on the left side, and we put the wire. And we tried to mimic the graft over the wire. So on this side, you can see that we are mimicking exactly the graft over the wire. And then we started to make the fenestrations for the innominate left carotid and left subclavian. You can see here. So the idea of this also was brought by Dr. Ma'moon, that we can cut the graft, whether it's PTFE or Dacron, but this was a PTFE graft, with a pencil laser that they use in the ophthalmology. So we brought a couple of them, and we started, after we calculated the distances, as we have seen from the control angiogram, we put marks on the screen, and we calculated where are the orifice of each artery, and we started to do, so we were cutting the graft with the sharp laser, and we make the 3 grafts as well. You can see them on the left side, how we cut the graft. And after that, we introduce the graft, and we open the first, and we just want to make sure that the innominate, because if the first artery is well selected and it's well perfused, then most probably that the rest of the arteries will be perfused from the measurements that we have taken. So what we do, we open the first stent graft after we calculate the number of stents that we have done the laser cut on them. And you can see on this slide that the catheter from the right subclavian approach had entered into the orifice, and before we open the stent graft, as you see here. And then we continue with that. We continue with the second, third, and until you deploy the whole graft from the ascending aorta to the descending aorta. And you can see the final angiogram. The orifices are well opened, the arteries are well perfused, and there is no need to obstruct or occlude the flow to the carotid arteries or to the brachiocephalic artery during the deployment. So the beauty of this is that you continue to have perfusion of these arteries. So in general, the pathologies of the aortic arch, I want to show you how is the evolution of endovascular grafting endovascular graft measurement for the arch is evolving as well. So the standard is still the surgical approach. Endovascular is emerging. We know that there was a gap in the treatment of the aortic arch because of the unmet demands for patients that they have high risk for doing a surgical approach. Aortic arch disease, the most common causes that we need to treat aortic arch is aneurysm and dissections. Dissections, they are emergencies, and aortic aneurysm, they can be elective, and then you can go and think about fenestrated graft. But sometimes, if there's an acute dissection, you need to go and do it immediately. So this is where this technique is helping you. Of course, to treat penetrating ulcers and intramural hematomas. And as I said, the clinical presentation usually depends on the disease itself. So the traditional has been surgical. It's associated with high mortality, and this is an article, even a revision of the open surgical repair. Still, it have a high mortality, high risk of stroke, and there was still a gap that surgery won't be suitable for at least quarter of patients that represent with aneurysms or with dissection. So this next evolution was the hybrid procedures in surgical procedures, the debranching, the graft replacement, and the total arch repair. And recently the FIT, which is less risky, but because you fix the descending aorta as well with the elephant trunk technique immediately, and this showed an improvement in the mortality and a little bit lower risk, but still the mortality and morbidity was still high with these techniques. So a number of endovascular techniques have evolved. We have 4 main techniques: the parallel grafting technique, the in situ fenestration, and the fenestrated or branched graft, and recently the PMEG. So this is the parallel technique, which you put either a periscope or a chimney stent from the carotid or the left subclavian, but this was associated with a very high rate of endoleak and also a very high rate of reintervention and mortality. So the other side is to do the in situ fenestration, like in this case, you put the graft and then you cut it with a laser or with the radio frequency, and you put a stented graft after you do a balloon, but you have to come from the carotid or you have to come also from the subclavian, and sometimes you need like a hybrid surgical technique, carotid bypass. And it has a very high technical success, a little bit lower mortality rate and lower stroke rate. The fenestrated, we have fenestrated or branch that you use a fenestrated and or branch technique by a custom made. But this needs a long time to bring, so it's only useful in very elective cases. Most recently, what we have is the physician-modified endograft, and there, as I said, there is now especially grafts that they are approved for PMEG techniques that you can cut and you can do laser and you can use them for acute cases. And I think, and this has been on the recent literature, though this is a new procedure, it showed that it has a little less risk of stroke during the procedure and a very high success rate compared. And this is a comparison between the treatment options, and PMG was not with them because, there is still little data on PMG grafts. So this is the outcome of complication of all the types, mainly long-term endoleaks, and long-term mortality is higher with surgical techniques, and it's much less with the new endovascular techniques. So how do we use the selection of the patient? How do we select that we want to do him for surgery or now endovascular? It depends on the presentation. It depends on the suitability for operation, if he is fit for the operation or not, and for the life expectancy. So these are the parameters that we study before deciding if we need to go for endovascular technique now or for a surgical technique. So the conclusion and take-home message is that endovascular techniques are becoming now useful in the treatment of aortic arch disease, especially in dissection and in aneurysms. You have multiple options, as we said, the parallel, the fenestrated, the branch, and the PMEG. And still we consider that the surgery is the gold standard, but we have now a very high technical success in treating aortic arch disease with endovascular techniques. Thank you.
Thank you, Dr. Hazem, for this great case. Now we are presenting our guest from Saudi Arabia, Dr. Abdulaziz Algethami. He is an interventional cardiologist and he's going to talk to us about dissection, reaching aorta, risk, and treatment strategy.
Well, thank you very much for the invitation, and I'm sure this topics that nobody want to show his complication, so it comes at the last of the talks. But I'm happy to present this kind of information. I'm sure there is a lot of experience going on in this room that will enlighten the discussion further. So my name is Abdulaziz Algethami. I'm actually consultant intervention structural cardiology at King Abdulaziz Cardiac International Guard, Riyadh. And it's always start with a case. So this patient is actually a female who had a STEMI kind of 2 months back anterior, and she had a cardiac arrest. And at that time, they did successfully revived her and implanted a stent. And we showed actually her angiogram from the other hospital before we intervened. And they came from a different hospital because they had that experience in the other hospital, and we decided to go for a complete revascularization of the RCA. So the plan was directly to go to the RCA and to actually intubate it and stent it. And as you can see, it's a GR4, and with the first injection, definitely it was a deep inside, and it's been extended to the aortic root as well as the ascending aorta. So what's the best strategy in here? Should we call for a cardiac surgeon because it's extended to the aorta? Or we change the guide catheter because this is aggressive one? Should we insert a wire? Or do an IFAS for these cases? So anyway, the incidence with the PCI is about very low, is a 0.02%. The RC involvement in about 75% of cases. And the diagnostic success with the angiogram is reached to 95 because the subtle ones sometimes it can be missed. But the more important is the Dunning classification, which is stage to 3 stages or 3 types. If it's involved only the ostium, then it is done in class 1. Or if it is more than the ostium and extended, but it's less than 40 millimeter, then it is class 2. And if it is more than 40 millimeter, then this is a class 3 of Dunning of the aortic extension from the coronary dissection. So what are the risks of the catheters? As you can see, this is actually a systemic review that looked all of reported cases, and you can see most of the guides can give you that, and also the diagnostic can give you that. And it's reported here the GR is the highest, but probably it is actually because they're most commonly used. But the more aggressive one, the AL, which is commonly associated with the dissection with the deep intubation, and they are is the ones that we do have. And as you can see, it happens also during diagnostic as well as during the PCI, more common during the PCI than the diagnostic because of the guide itself. And it is actually a retrograde extension. It's iatrogenic most of the time, and it is a clinical urgency that we need actually to deal with it. So what are the primary causes of this? The primary causes is guide catheter trauma. It's either from deep intubation or direct injury with vigorous contrast injection, especially machine kind of oriented injection. Sometimes it's associated because of subintimal wiring, especially if left main or in the ostium of the RCA with abnormal takeoff, and sometimes associated with the balloon inflation of the ostium, especially oversized balloon. So there is some scenarios that it is associated with the higher risk for dissection. Patients who have CTOs, patients who use amblats left for deep intubation. Sometimes it's complex bifurcation, left main can give you, especially with the balloon end when you do have a double crescent balloon. And if you use a bulky devices or rotablation or other devices that might actually cause dissection, especially if it is higher pressure kind of inflation. So the diagnosis mostly is through coronary angiogram, and the earliest sign is the contrast resistant and the staining or handing. The intimal flap is kind of more obvious. And if you do see the double lumen is more kind of, you have a true and actually false lumen to diagnose it. The intravascular ultrasound is usually not indicated for a diagnosis, but sometimes it's indicated for optimization of your stent and seeing the ostium if been covered or not. Now, the CT scan is important, and the main reason is to do the baseline extension of that kind of dissection, but that does not deter you from management acutely in these cases. Sometimes you do need to have a serial follow-up, but not all cases, definitely. And sometimes you need to exclude some complication from your intervention. So what's the emergency management for that? First is stop the contrast injection, try to do ostial stenting, and check the hemodynamic if there is a need for support or not. And lastly, consult the cardiac surgery if you think that the patient is collapsing or there is other indication you cannot really reach to a good perfusion of the coronaries. So conservative management sometimes it's more for class 1, and class 2 is something between conservative versus actually active management along with the class 3, and that's related to how's the extension going on and if it is less small or it's only going to the cusp without actually involvement of the ascending aorta, and if the actually cusp had been stopped or not. And also related to the patient itself, if he's stable, he's not stable, you finished your work or not, is the lesion is actually at the ostium or at the distal vessels. So it's all depend how you're gonna see it, and sometimes you have to wait and see, but definitely not in our case, what I did show you earlier. So be careful with the ostial stenting, because these patients, you do need to cover the ostium, but very important to choose the stent. Most of the times, drug-eluting stent or bare-metal stents, if it's a large vessels, will be enough. Sometimes covered stent is important for a patient who does associated with perforation. The deployment is very important to maintain that you do cover the ostium. And the IBUS sometimes help to assess if you do cover that or not. So the indication for surgery, if it is more than 40, we might think about it, but that does not mean that it is a rule. And if there is a hemodynamic instability, or you failed stenting that artery. And if you do have, of course, aortic valve involvement, that's another indication for intervention surgically. So this patient, because at the time when we do the case, there is no time to do a cine every time. But definitely, the first step we did actually, because we do have the guide, is to insert a wire. And the first wire buckled, so we kept it in the same place, and we tried to have another wire. And successfully, we went through the second wire, then we implanted a stent. Then we removed that kind of wire just to make sure that we are covering both, especially there is a lesion at the distal BDA, then we remove it totally. But as you can see that the dissection actually extended a little bit more further in the upper part, but it was kind of a stable kind of dissection, and it didn't show any further kind of progression. Despite that, we waited almost like 10 minutes to have more injections and to make sure that there is no more extension. So in patient like this, the catheter technique and manipulation is the only way to prevent these kind of catastrophic events. And the injection might be, if we do have an injector that's handheld, maybe it is more softer in the kind of artery. So the perils of aortic coronary dissection, the best treatment is the prevention. The most important management step is stopping injection and having a wire inside the true lumen. And be aware of the geographic mass of the ostium when you are stenting that ostium. Thank you very much.
So now we can move to our friend Dr. Amr Alkermi. He is going to talk to us about this exciting title, Cannot See, Cannot Kill, Column, Acute SPG Occlusion.
Dr. Amr, the stage is yours.
I'm going to make it as a last quick message. Or by the end of the day, I think everybody's tired. So this is a lady in her 70s, known previously with coronary artery disease, cabbage 15 years ago with edema to the LAD and SVG to the diagonal and OM. She's under regular follow-up as typical diabetic, poorly controlled, hypertensive. Usually she's okay, slightly shortness of breath every time and then, and slightly high blood pressure, but she manages well. Recently, recurrent episodes of angina, a couple of ER attendances with negative cardiac enzymes, and we've started to notice that she's having more of PVCs. Her creatinine 1.4, and usually I do like to CT most of previously cabbage patients, but for her creatinine we said, okay, we'll just go straight for coronary angiogram for contrast load. Okay, now I think you have to do that. So that's her native coronaries. You can see severe left main into an occluded LAD. Next. And run that, please. Oh, is that running? Andy? Okay. So just to appreciate the anatomy. And that's her venous graft to the OM, nicely patent after 15 years. That's her right coronary artery. And we can see that there is a proximal ostial lesion. That's her lima, which is the interesting site, interesting bit. And her lima looks like it's attached to a septal, not to the LED. And that's just to confirm. Oh, really? Okay. And I came back to look for her remaining SVG. And I can see an osteal disease with the rest of the graft is patent. So we stopped at this stage and start to discuss, shall we do the ostial vein graft, or is it the right, or while we're discussing, she's heavily sedated. She's one of those nagging patients. And while we're discussing that, she's just woke up. And she said, I got chest pain. And we start seeing her blood pressure dropping and her ST segment in lead 1 on our cardiac monitor start to go up. Came back, just had a quick look, and that's her graft to the LED. Rapid deterioration with the patient, almost semi-arrest since he was in a peri-arrest state. So I was a bit scared that if I'm going to lose my diagnostic cath in this patient, I will never find it again. So with that diagnostic cath, I passed the wire. Okay. No, that's that one. So with the diagnostic cath, I passed my wire, and I took my chances. I passed my balloon. I inflated the balloon, and I flew back. And then on the same coronary wire, I took my diagnostic out, and I got my guide back in. and I finished my angioplasty with a single stent. The rest is history. So the quick message is, diagnostic cath, we can do at least balloon angioplasty. In some guides, even 6 French guides, you can actually go with to do full intervention. And thank you very much.
Thank you. We can open the floor for questions. This is our last session of the day. Anybody? Raed, please.
Oh, okay, now. Interesting cases, actually, Amr, Abdulaziz, everyone, Dr. Hazem. Actually, everyone asked me to ask a question for every one of them. Dr. Am I allowed to ask everyone one question, or okay?
Just start with one, then we'll move on.
I will start with Dr. Abdulaziz because he's our guest.
Dr. Abdulaziz, do you mind coming here?
I'm quite sure that everyone doing coronary angiogram for a quite long time experienced same complication, and I have done many of them, just to admit. How you be sure that the wire will go in the true lumen? What are the techniques that you do to go to the true lumen to solve such a problem?
Well, definitely you will not really choose a non-hydrophilic kind of wire. The idea is to make sure that there is no buckling on your wire. And if it goes beyond the dissection in branches, like a CTO kind of thing, then probably that's another idea that you're on the true lumen. But some other ways, you might actually go for imaging, you can actually confirm it. But some of the CTO skills goes on that. First, there is no buckling in your wire. Second, it go inside branches. So you make sure that you're actually likely, this is the first branch, you go into the other one, you're on the true lumen, you're greater, and there is no much resistance. But you cannot really guarantee until you do feel it. I do not think that I'm more experienced than you. I think you can actually say that, all answers for this. But that's probably how I think about it. When we introduced the wire for this case, it was buckling. I left it in the first place because I want to go to another area. But unfortunately, you know, with the rush, you cannot really fluoro-save it, and you cannot really do cine because it's time consuming. You want the wire in quickly. So you leave it as you're doing the parallel wiring, you know, the CTO technique. You leave it where your wire is, it's buckled, you take another wire, you go to a different area. Then you go to side branches, then you go, now you're actually in the true lumen.
Well answered, Abdulaziz. I have 2 points here, just to add them if you allow for me. The first thing, yes, you go with buckling if you are in the subintimal or in the nut of the true lumen. And in this case, you need to pull back the catheter a little bit so you will be able to go to the true lumen. But what you are afraid of, if you do this, that you will lose the engagement and everything jump out. So what is safer is to go with another axis, to have another catheter, and to put it beside it. And that one, the catheter is already blocking the false lumen with the wire buckling there. And you go with the other catheter beside it, and you go the true lumen very easily.
Any other questions? Dr. Abdulaziz, I have a question for you. So in your case, what was the outcome for the lady?
The outcome, we did actually a CT after we stented the proximal RCA, and there is no dissection. What we do see in the angio is very huge kind of flap. But when we did the CT after the PCI, 4 hours or 5 hours, there is nothing. There is no contrast on that. It healed.
Yes. So my question to you, what is the time you decide is this? Hello? Yes. So my question to you, when do you decide, based on the extension, based on your done classification, that this patient should go to surgery immediately? Like if you say 10 centimeters above the aortic, above the ostium of the right coronary artery, you will decide to send the patient regardless to surgery, or you just go ahead with your plan, stent and watch, I mean, is there a number you look at and say, this patient will not heal, she needs to go to surgery?
Yeah. Well, it's all dependent on the situation, tell you the truth, because if the patient you cannot wire and it's a patient is already hemodynamic collapsing, then probably this is a patient I should call the surgery directly. But because I kind of successfully went through that kind of dissection and I had the true lumen, then I'm more kind of comfy not to call the surgeon immediately. Another indication, if it is going to the valve and you're seeing that actually the dissection going to the cusp and down to the valve, then that's probably you think, oh, maybe there is actually regurgitation. I might actually do something regarding and call the surgeon. But the more kind of quick to do it and you stent the ostium, probably gonna heal. And that's what happened when we stented. We waited, we did another injection, we said that there is no much of extension. We waited more, we did another injection, and it was fine. Then we thought that it is going to be safe to leave it alone.
Yes.
But I think that I answered the question.
Thank you. I think most of us will share that, yes, it is a drastic complication, but always if you stent the ostium of the right, it's benign. How many of us did an aortic ostial right dissection ending with sending the patient to surgery? Anybody remember a case? Tell us, Raed, what happened?
I regret that was at the beginning. Yes, I had RCA with aortocoronary dissection, and I referred him to surgeon. The patient actually died with bleeding.
With surgery, exactly.
Yeah, so I think solving it inside the cath lab. After that, I never ever treat or sending patient to surgery. Still, if you have, definitely, as you mentioned, if you have involvement with the cusp, you have significant leak in the aortic valve, yes, we need to send the patient to surgery, whatever it takes. And if you have really progressing dissectioning above the sinotubular junction and more than 40 millimeters, they estimate it like this, yes, I think it is indicated actually to send him for surgery. But otherwise, no, treat him inside the cath lab.
Okay. My question to Dr. Hazem. Dr. Hazem. Hazem Habboub موجود. Okay. Yeah. Thank you. Dr. Hazem, you put the graft stent in a two-dimensional view, and then you take it out and you do the holes that needs to be in a three-dimensional way. So you might know the distance from the aortic cusp to where the hole is, but exactly where the hole should be, how would you decide that without 3D?
No, we have the 3D. I mean, this patient had a 3D CTA before, so we know the distances. But we want to make sure that the holes are in the proper position of the aortic arch in this projection. So this is why you do them on both the 3D, CT angiography, and on live on table.
That makes sense. Thank you.
Can I ask also, Dr. Hazem, is there a way to go retrograde, for example, from the arm and then put a marker where you want, is there something that you can mark intravascularly or something?
But then you have to do it for the carotid, the innominate, and the left subclavian if you want just to make it, I mean, this and by this you have to occlude the flow to the carotid and to the subclavian. And probably this is one of the major things that's causing still high rate of stroke with the fenestrated and branched stent graft for the arch. But with these techniques, you keep the flow while you are doing, because I mean, you're doing this outside. So I think it might be very helpful in the future. We just need to see how it's evolving for the treatment of dissections, for type A dissection. Especially type A that they are 2 centimeters above the cusps.
Since Hazem is there, can I ask him, Dr.
Yes,
Hazem,
please.
what's the relation between how hemoptysis happened with this aortic problem? I mean, hemoptysis, how do you explain it?
Well,
I mean, I don't know what's the relation.
This is inflammatory. I mean, you know, this is an inflammatory ulcer. It can go into any bronchiole and start hemoptysis. Just like it has caused paralysis of his recurrent laryngeal nerve, it can cause perforation into a bronchiole.
And after fixing the aorta?
After fixing the aorta, he was with Dr. Momin. I think he stopped having hemoptysis.
Yeah, he fully recovered from that dangerous symptomatology. And I second what Hazem was explaining. dangerous hemoptysis, especially in Bahjat disease. This is a Bahjat disease patient.
Exactly.
Can happen because of erosion of the false aneurysm into the respiratory tract or the esophagus as well. And there was extreme thinning with the esophagus. And one of the main points that we tried strenuously to attend to is the infection risk, because this patient is immunocompromised because of the immunosuppression. And with hemoptysis, he's still at risk of getting the graft infected. He is and he will stay on oral antibiotic therapy for a long time to come. And if I may comment one thing just to add to what Hazem said, the secret with this patient specifically, with the physician-modified endograft, is non-puncture of other vessels, because in Bahjat they get false aneurysms where they puncture them. And if you're going to do an intervention which involves the carotid or the subclavian, you'll have to puncture it, and that's extra risk. To be able to do this fully from the femoral approach is a very interesting and impressive thing.
Great.
So back again to Dr. Hazem. Dr. What is the follow-up for those fenestrations you do? We know about the graft, what's the outcome. But when you do, for example, a graft with chimney, with fenestration, and you put stents there, what is the outcome of those fenestrations, the ostium of that chimney that you do? Do we have that data?
Yeah. It was in one of the slides. The rate of endoleaks from the fenestrated is the least, less than the
I'm
branched
talking about
vessels.
stenosis.
Stenosis of the stent graft.
Of the ostium of the chimney, yes.
Very low risk of
Very low.
stenosis, yes.
Yeah, though it is a grafted one. And we have bad outcome ourselves. When we put the grafted stents, they don't do good. So maybe because of the larger diameter.
Yeah, according to Charing Cross now, they consider the fenestrated, if you can do it, is still, the gold standard endovascular. Still, we said that the gold standard is surgery. But fenestrated. But, fenestrated, we have two important issues here. The time that you need, because this patient, we wanted to wait for him, but he kept having severe hemoptysis, and we have to treat him. The other thing is really the cost. The cost, the cost of this technique, I think it's like 1/3 of the cost of fenestrated.
Yes.
Ma'mun knows better about the cost, but really it was very cost-effective technique to do it, and I think in Jordan it is a life-saving technique and affordable and very cost-effective.
Yes, right.
Can I ask Dr. Amr?
Yes, Amr.
Amr, so very nice case. I like your quick thought of going there, putting the wire by any catheter you have on the diagnostic, and you open the vessel. You're not able to go with a stent in the diagnostic definitely, and you want to stent it. That's why you need to go for guide catheter. My question is, it's not my question. If you allow for me. My question is, you have the PTCA wire, and you change the catheter, the diagnostic to intervention to intervention catheter. I think it was left Amplatz 1 or 2?
AR1.
AR1, I think AR1, yes. So AR1 used AR1, and this AR1, how did this BTCA wire carried the catheter?
I think I was lucky.
You was lucky. Do you have any way to be sure that it will have more support and to have?
I can put another wire. I can put 25 instead of 35 wire. It will carry both wires, the guide catheter. Or I can take a 7-French guide. Or actually, you've got a flow. Do you really care if you lose the wire? I've got the flow in that one. So I was trying it as a matter of whether actually I will get the wire held in or I will lose the wire. But at that stage, I had a flow in that graft, so I can find it. It's not a big deal. The idea is to restore the flow. And when you got the flow back, you can actually even take your quarry wire, put another Teflon wire. Just
another quarry wire is the way.
So you got a flow. You're off the hook. You're just past that stage when your patient is arresting, basically. And we got the flow back. You've got time. You can do whatever you want at that stage.
So I think, yes, putting another coronary wire as 0.14 and you go with the, so it will be easier to carry the catheter, yes.
0.18 even.
Do an exchange if you keep the wire, if this is, I don't know, maybe use the shorter wire, not the 300 wires.
Yeah. No, that's a
But
normal corner.
another idea is to put the wire in, and if you are an arm, if you are working it through the arm, do the exchange on 2 wires, keeping the first wire in, and do the exchange from the arm. Take the diagnostic
That was a femoral
out.
actually because it's patient graft. So
but
was
I
a
guess
femoral,
there's no
which
problem.
is easier basically.
I mean, most likely what happened with your case is the catheter tip, right? That caused the occlusion or the dye.
I think she was bending. I mean, there was at the catheter tip. I think she was recently in the hospital ER with chest pains in and out. So I think there is something in that occel graft probably,
Yeah.
and probably clot dislodged
Yes.
or just a debris, which is a vein graft. It's 15 years old vein graft. So
Yeah.
any debris will just go.
So do you think that if you have not done anything and you took everything out, put your guide and go for wiring would have made a difference? Do you think that wire through the diagnostic catheter made a difference to you, that you would advise all of us if you had an occlusion during a diagnostic to put the wire?
Probably saved me about 3, 4, 5 minutes. That's
Yes,
the only thing.
yes.
So basically, because when we were discussing either with between the team and with the family about putting that the patient need a stent into that graft and whatever, and she started to arrest. So we didn't know which graft is occluded or where is the lesion. So I went back with the diagnostic. So if I'm going to go and get an intervention kit done, while just putting that wire, I started to have a flow with the wire.
Okay, I promise last question. When the patient coded or near coded, why didn't you go with a guide from the start rather than a diagnostic then a guide? You know something is bad happening.
Yeah.
Why didn't you choose to go with a guide?
The family didn't agree on the PCI at that stage.
Okay. Thanks, good answer.
Okay.
Any other questions? So with that, I think we wrap the first day. We thank the audience very much for sticking with us, and we'll see you guys tomorrow morning.
يلا الله يعطيكم العافية. بس في شكر خاص للدكتور عبد العزيز، يعني بصراحة أخذ الريسك، أخذ الطيران، وبصراحة بنحييك يا دكتور عبد العزيز، وأهلا وسهلا فيك، وهذا بنعتز فيك إحنا، هالمحبة الكبيرة لإلنا ولإلك رح يكون متبادل إن شاء الله. بكرة لقاءنا الساعة 9 رح يكون فيرتشوال من أمريكا، روبوتيك سيرجري، 2 excellent رح يكونوا عندكم presentation keynote lectures، وبعدها رح يكون من تركيا virtual على الدراج كوتينج بالون، بعدها رح يكون في عندنا cases. بكرة the day of complications رح يكون عندنا حوالي أكثر من 12 حالة فيهم complications. يلا يعطيكم العافية، ونراكم غدا الصباحا الساعة 9. الله يعطيكم العافية جميعا.